Hello and welcome. I'm Matt Kroh. It's my honor to introduce Dr. Alia Qureshi, who is from Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, Massachusetts. And she is our moderator for our session tonight.
Wonderful. Thank you very much for that introduction and welcome everybody. I have the privilege of doing the introduction for this. And I would just like to advance my slide, and I apologize, I'm having some technical issues advancing. And I'm not sure why that is. Okay, I will stop the share, and for some reason it won't let me advance otherwise. Okay, well then I will share in this format. So I would like to just give you the highlights about the webinar today. And basically it is with regards to the new practices in the recruitment for enhancing the academic surgeon pipeline. And this is a webinar that is organized by the SSAT Diversity and Inclusion Liaison Committee. We have a number of excellent speakers from across the nation. And each of these speakers will be speaking specifically to issues with regards to the pipeline. And I will just briefly introduce the objectives, and then Dr. Kroh will go on to introduce the speakers themselves. So I'll just go through the objectives of each speaker, and Dr. Kroh and Dr. Zundel will be moderators to guide the discussion forward. Our first speaker will be Dr. Nfonsam. The objectives of his talk will be to identify the phases of the surgeon's pipeline. Secondly, to recognize the most common leaks within the surgeon pipeline. Our next speaker, speaker two, will be Dr. Rebecca Minter. The objectives of her talk will be to discuss the novel approaches for posting open positions for academic surgeons. Secondly, she'll speak to determine the characteristics of an effective talent pool. Dr. Amy Halverson will then speak on the objectives to recognize the most common biases in surgical recruitment. Secondly, she'll speak on to identify approaches to reduce biases during the selection process. That will be followed by Dr. Karen Chojnacki, and the objectives of her talk are to understand the importance of the use of standardized interview systems. The second objective is to recognize the key points in the negotiation for successful outcomes. And we will finish the talks with Dr. Stephen Stain, and his objectives are to identify critical predictors to achieve successful retention rates. Secondly, to recognize challenges of tracking progress and determine faculty advancement. And finally, closing remarks will be done by Dr. Juan Barajas-Gamboa, and he will close out this webinar today. Thank you.
So I think with that, we'll move on to our first speaker, Dr. Valentine Nfonsam. He's from the University of Arizona Health Sciences at Tucson, Arizona. And Val will be speaking on potential leaks in surgeons' pipeline.
You see my screen? Let's see. All right, so I wanted to start by actually thanking the SSAT for giving me the opportunity to kind of talk about this really very important topic on potential leaks in surgeons' pipeline. I have no disclosures. One second, yeah. So women, and especially underrepresented minorities, are still very underrepresented in surgery. And this representation is actually even more significant in surgery leadership. Now, these two groups are disproportionately faced with challenges, which includes systemic racism, socioeconomic factors, sexism, and also the imposter syndrome. And this actually perpetrates this concept of a leaky pipeline. It is well established that a diverse medical and particularly surgical workforce ultimately reduces healthcare disparities and improve patients' outcome. Diversity has been shown to improve not only access to healthcare for underserved patients, but has also shown that underrepresented physicians and surgeons are more likely to practice in underserved communities and treat patients irrespective of their income. Women physicians have also been shown to treat similar patients. There is actually increased patient satisfaction when patients are treated by physicians from similar backgrounds. Now, despite all what we know, despite all these established facts about the importance of diversity in surgical workforce and the role it plays in improving outcomes and patient satisfaction, despite all of this, we still continue to struggle to establish a diverse surgical workforce. And this lack of diversity is even more accentuated in academic surgery. One of the most talked about ways to diversify the surgical workforce is actually to improve the pipeline. However, we all know that this pipeline has proven to be very leaky. In this study done by Catherine Bingman, looking at data from the US Census Bureau and also the WMC from 2004 to 2018, they actually showed that women comprise 50% of the population and 32% of surgeons, and representation is increasing at a rate of 0.4 per year. In addition, they showed Hispanic represents 18% of the population and 6% of surgeons, and representation is also increasing at a rate of 0.04 a year. Interestingly, 13% of the populations and just 6% of surgeons are Black, and representation is actually decreasing at a rate of 0.1% per year. Now, so this actually shows that while the proportion of women and Hispanic surgeons is slowly increasing, the proportion of Black surgeons is actually decreasing. In this other study done in 2018 by Halverson, looking at minorities in surgery, they actually showed that there is significant racial and ethnic underrepresentation in surgery, and this actually increases through the academic ranks. More disturbingly is that this has not improved over time. And this study actually reinforces the findings of the previous study. If you look at here, again, the general population, Black patient, Blacks are 12%, and they comprise just 6% of medical students, and 5% of general surgery residents, and 4% of assistant professors, and just 2% of full professors. Again, clearly showing that this pipeline is leaking, especially in surgery. So it's obvious that this pipeline is leaking. Now, this leaks actually start all the way from grade school, but it becomes more critical from medical school into surgical leadership. Now, the question is, why is this this leak? Clearly, this is multifactorial. I would say one of the biggest contributors of this is socioeconomic factors. The challenges faced by people from poor socioeconomic backgrounds can at times prove to be insurmountable. Poor schools with lack of infrastructure, lack of after-school activities, gun violence, single-parent homes, and poverty. These are all factors that actually make significant holes in that pipeline. And these factors needs to be addressed in order to plug that hole in the pipeline. So another crucial factor is the lack of mentors and role models. This spans actually from grade school all the way to surgical faculty level. Having mentors and role models from similar backgrounds could actually be very important. We all know that mentorship is not enough. To improve the surgical pipeline, we need sponsors, allies, co-conspirators, and these are all people that actually help not only plug that hole in the leaky pipeline, but also help to advance underrepresented minorities and women in the surgical workforce. These are often very lacking. We also know that diversifying is not enough. Lack of inclusivity creates an unwelcoming environment, and that stifles creativity and also amplifies the imposter syndrome. One of the things that is often overlooked and the cause of this leaky pipeline is actually poor design of pipeline programs. So again, this is something that could be addressed. So how do we fix this system? How do we plug this leak? The only way this could ever be fixed is that there should be some kind of intentionality. Most people recognize this problem. Most people know the pipeline is leaky. People talk about this all the time. If there is no intentionality, the problem will never be fixed. This truly starts from the top and permeates down to create a lasting culture. If the leadership doesn't intentionally want to fix this, we can talk about this till kingdom come and nothing would happen, or the changes will just be cosmetic. We have to intentionally set and measure metrics that are intended to address diversity. If I live, for example, in the state of Arizona and 40% of the population is Hispanic and 3% of the medical students are Hispanic and 5% of the surgical residency residents are Hispanic, that's a problem. That's a problem. So in this state, we intentionally try to fix that because we had a leader who believed and held people accountable. And so that's important. That segues to the really importance of intentionality. We transformed the APDS, for example, but when the organization decides that, you know, we really want to look into creating a diverse surgical workforce and plug that leaky pipeline. But what we did was that we started by looking inwards first, looking at our leadership in the last decade. That actually showed to me that there was some intentionality in them really trying to change this process. And the results were eye-opening. We were intentional about that. So the other thing that, in addition to intentionality and trying to help plug this leaky pipeline, is that we have to have well-designed pipeline programs. And one size does not fit all. So again, that's a problem when we take something that works in one environment and feels that it should work in another environment. So we have to recognize the background and cultural differences, and also, more importantly, include designers with similar backgrounds and experience, like the environment you want to change. And to plug this leaky pipeline, we have to start by increasing and improving the pipeline. We have to go all the way back to support STEM programs and getting underrepresented minorities and women interested in science. There should also be targeted high school, college, and medical school outreach programs, and also supporting minority scholarships. And one of the most overlooked programs that is very instrumental in getting underrepresented minorities into medical school and then into surgery is the post-baccalaureate program. And most of these programs need to be established. More of these programs need to be established. So we need to have outreach programs partnering with medical school, undergraduate school, undergraduate and high schools, and also underrepresented in medicine organization. We also need to approach medical schools and look for mentors and sponsors that are interested in surgery, going through all these organizations that are important in advancing diversity, especially in medical schools. That would be the Latino Medical Student Association, all the way to the SNMA and Association of Native American Medical Students. We also have to volunteer to actually participate in workshops, like in regional workshops and local workshops, and try to recruit and showcase programs that actually attract underrepresented minorities and women into medicine and surgery. One of the things that is really important is writing supportive, unbiased evaluation and letters of recommendation. This is actually really common, and there's a whole lot of studies done on this that shows that underrepresented minorities, the letters of recommendations are not always as strong as it should be, and also on their clerkship grades. Everybody needs a mentor. To increase this, we have to offer mentor-sponsored student clerkships for underrepresented minorities. There's a lot of great programs now that offers and institutions that offer funded away rotations for minority medical students. We also have to prepare students for medical student residency interviews. I mean, there are multiple webinars like this that have been done to prepare medical students and residents into for interviews. But more importantly, this pipeline continues to leak all the way to academic faculty, and where we see less and less women and underrepresented minorities advance academically into becoming full professors. So there is significant role in mentors and role models. So everyone needs a mentor. And we want to support and engage faculty and current residents as mentors, research advisors, as teaching assistants for pathway programs, lots of pathway programs, and that addresses at any level from high school, college, post-baccalaureate, medical school, and residence applicants. So mentorship is actually very critical. And we have also shown in multiple studies that, that having mentors that have the same background and similar experiences always helps significantly in plugging that pipeline and pushing people and making them look forward, reduce the imposter syndrome, and actually achieve a significant diversity. So some of the outreach programs, like some of the ones we do here in Arizona, for example, the Frontera program, this actually is an outreach program for border and rural areas, targeting minorities, especially Latinos, and trying to help them recruit them over the summer, not only to medicine, but into surgery. So a lot of the surgery faculties are actually involved in this program, and it's been very successful. A lot of the students actually end up in medicine, and the ones that were mentored by surgical faculties actually end up in surgery. So, and I also know that the College of Medicine actually have a high school program, and that I think where they go to underserved areas and invite high school students into the college. I think it's called A Day in the College. And that also, I remember participating in that several years, and I still keep in touch with some of those students. Some of them are applying to medical school now. I think those are all great programs. So another thing is recruiting. Recruiting has to be holistic. You have to engage faculty and residents from different backgrounds, showcase the program, be it from high school level to the residency level, or even recruiting faculty. We have to consider scheduling interviews when there are multiple diverse candidates, and also that the people interviewing have a diverse background. Well, especially for faculty recruitment, diversify the search committee for faculty recruitment, implicit bias education for faculty development. All of these things actually help stem that leak that we see, especially when you approach surgical residency level, and also surgery faculty level. Some other additional things that help in stemming that leak is, updating the website and ensuring that every member of the division or the department or the institution espouse the value of diversity, and that's really very important. We all also know that recruiting diversity is not enough. Retention is actually equally important for the surgery pipeline. We have to create a welcoming culture and environment, zero tolerance for any form of discrimination. Having diversity champions have been shown to help, and also having mentors that come from a variety and diverse background is also very helpful. We also want to support representation in national societies, and this includes Association of Women in Surgery, to Society of Black Academic Surgeons, Society of Asian Academic Surgeons, or Latino surgical societies. These are all really important in providing an environment that supports diverse faculty, that all students or medical students, and in so doing, that pipeline becomes less leaky. We also want to support residents and faculty from different religious backgrounds. For example, we have students that and residents in our program that wants to wear their hijab in the operating room and have issues with that, stuff like that. You create an environment and support that, and that's important. We also want to support or create an environment where that supports diversity in not just only socioeconomic, gender and race, but also espouse sexual and gender diversity. So I would say creating opportunities that support and promote underrepresented women and minorities to higher academic ranks and leadership position is really important in stemming the leak in that pipeline. So in conclusion, there is a significant value to having a diverse surgical workforce. We all know that. The surgeon's pipeline is clearly still leaking, especially for African Americans. The reason for this leak is clearly multifactorial, and plugging that leak has to be intentional. I want to close by saying privilege is being given the benefit of the doubt. Women and underrepresented minorities should actually use this too. I just want to thank a whole lot of people that are involved in this, especially in the APDS, as we develop a diversity toolkit. And thank you, and that's the end of my talk, and I'll take questions after. And I'm going to stop sharing.
Thank you, Dr. Nfonsam. That was an excellent talk. And just a reminder to the audience, you can pose questions to our faculty by the chat. We'll be keeping track of this, and we'll have time at the end for all the faculty to answer questions for each of you. So our next speaker is Dr. Rebecca Minter from the University of Wisconsin, Madison, Wisconsin, and she will be speaking on new recruitment approaches and pool selection. Welcome, Dr. Minter.
Thank you so much. The most challenging part of this is always actually sharing the right screen, and I'm not getting it to come up. Do you see my slides full screen?
We see them in slide sorter mode.
Okay, I'll try again. There we go. I think that's it. How about now?
Yes.
Okay, after 2 years of this, you would think. A competency I am still working on. So thank you so much for the invitation to join this esteemed panel today to talk about something which I'm really excited about and have learned a lot and am absolutely still learning. I was asked to really talk about thinking about a new approach to recruitment, and I have no financial disclosures, but will certainly disclose that I'm learning along with all of you. This experience that I will share with you today has been part of our strategic plan for the department and our domain of diversity, equity, and inclusion, and I think is probably one of the most important aspects of our strategic plan. I know many of the speakers will reinforce some of the things that I'm going to touch on, so I will touch on them superficially, but I'm happy to talk about anything in greater detail during the Q&A session. So, Jim Collins in Good to Great said, get the right people on the bus, get the wrong people off the bus, and get the right people in the right seats. And we all thought that was revolutionary. And of course, it makes perfect sense. But how do we actually do that is the question. And I think as we think about revamping something, we have to start with where we are today. So, what does current state look like? I've been at 3 institutions. They've all had a somewhat different approach, but I would say the themes have been, in general, we hire our friends, right? And hopefully nobody is hiring Bart or Millhouse, because that would just be a bad decision. But I think in general, we are like, oh, wouldn't it be great to work with so-and-so? They're really great. We have a lot in common. And I think even if you don't hire your friends, you hire people, generally speaking, a human nature, who seem to think like you do, who are going to, quote, fit in and add to your team in a way that's going to be what you view as very cohesive. We also had this myth of meritocracy, and I love this cartoon, but this idea that, if you just work hard and you do a good job, and somebody's going to notice and you'll be given the opportunity. And I think increasingly we know that that's absolutely not the case. And I would say I've really come to appreciate that more and more as I've moved into roles of chair, and you get contacted by all these search firms, and it's, can you recommend somebody for this new great opportunity? And it's always the same 10 to 15 names that are circulating. You would think there's only 15 qualified people in the country for all of these opportunities and positions. And the reality is that social capital matters a lot in medicine, and underrepresented minorities and women are given fewer opportunities. And so it becomes this cycle where the big fish gets bigger and bigger because they are given more and more opportunities, and the medium size and little fish stay medium size and little and keep getting passed over when the opportunities come forward. So Dr. Nfonsam talked a lot about intentionality, but I think that has to be really a key takeaway from the session today. So my thinking about this really changed when I was at the University of Michigan and had an opportunity to hear from this gentleman, Scott Page. He's a political scientist, professor, and he's also has an appointment in the Ross School of Business. And Scott is really done what I would say is just revolutionary work in terms of thinking about why diversity matters. And he's written several books, but the one that I would call out that really has been impactful for me is the third one, The Diversity Bonus. And Scott has a body of work in this book that outlines and identifies how diverse teams always win. They always win, they always outperform. And he's applied, economics to this and outputs that really nobody could argue with. It's a really, really powerful book that I would recommend to everybody. And so as I listened to him and read this book, it really struck me that, we're not set up for success to actually develop diverse teams or to recruit diverse teams. So how could we do that? So we have taken a different approach. We've just implemented this in the last year. We've borrowed some ideas from University of Michigan, but really primarily have partnered with Hope Barajas, who's our Senior Associate Dean for Human Resources here in the School of Medicine Public Health, who came to us from Stanford a couple of years ago, and really thought about how we should re-engineer our approach. And we really started first with the process. At the University of Wisconsin, we actually are required to have a search committee for every recruit, no matter what it is. And that was not true at some of my prior institutions. We might have a search committee for a chair position, but often the recruitment did not have a search committee. But even though we had a search committee, often the searches were being run through the divisions, often by the admin assistant for a given division that was doing the hiring. And it turns out that human resources and recruitment is actually like a whole profession. And there actually are ways to do it well and ways to not do it well. But our, kind of historic state was that a very decentralized, different committee every single time. We kind of did our best to do some bias training, but we didn't do it very well. And then we would move forward with the position, again, often hiring our friends or the people who thought like us. So this is, as we moved forward in this, one of the big changes we made was we said, we're going to have a standing faculty recruitment committee, and this is going to be a diverse committee, and it's going to recruit for all of our positions. For a given position in a division, they will add, 2 ad hoc individuals, 3 if it's a leadership position. But the standing committee will do all of our recruitments, and that we'll have a standing chair of the committee right now, who's Scott Chayette, one of our otolaryngologists. We now have actually, because we've been so busy, have split this into 2 standing committees. The important thing I want to call out on this slide is on this committee, we have residents. So Betty Allen is one of our PGY3s. We also have APPs and we have staff. And this was really important to us because when we're recruiting faculty into the department, it's important that they will be supportive of our staff, of our residents, of our APPs, who are important stakeholders in the department. So we were very intentional about what were the positions on the faculty recruitment committee and how we appointed individuals to them. This is a big, big time commitment, but it's been really incredible to see how much folks have really dived into this work. And as you'll see, it is a lot of work and are really incredibly committed to it. So in addition to taking, looking at the committee differently, we made sure that the committee had deep, deep training in bias mitigation, and our subsequent speakers will speak much more about this, but I'll just mention that we have this incredible resource here at Wisconsin called Wisely. They have fantastic tools for anyone who is interested in utilizing them. They've been developed under Molly Carnes and E. Fine's NIH-funded program in this space. And so our whole committee underwent many, many hours of bias training so that as they entered into this work, they had a better foundation in terms of bias mitigation. We also focused on competencies, and we did this for the committee. We didn't start off by naming people to the committee. We started off by saying what competencies and skills and representation do we need on the committee? And then we came together with our leadership team and we mapped people that would meet those competencies. And when we did that, we did it with pictures of all of the faculty in the department, pictures of all of the residents, and pictures of all of our staff and APPs. And that was really important because, again, back to that myth of meritocracy, otherwise you come up with the same names every single time and you give that opportunity to the same people every single time. So that's how we constitute our committee. Very importantly, we've taken a competency-based approach to every position. So often, again, in current state, many times I've seen this happen. People write the position description for a specific individual, and we have banned that from being possible. So the division chair is not able to be on the search committee, but the division chair helps develop the position with our faculty recruiter, and they have to start with what are the competencies needed for the role. We have a book of 44 competencies. They can add others, which are shown in the left column here, but then the division chair has to add the narrative and define how important it is in the process. Because leadership could have a different need for one position than another. What are the aspects that are really critical for this role and the person that you're seeking for this role? So once the competencies are defined for the position and are iteratively worked through between the chair, the search committee, the division chair to make sure there's clarity about what they need in this person, then the position description is codified and posted. Then we post the position broadly. We post it in all of these different places. And I naively thought early on, I was like, oh, this is going to solve the issue. We're going to have a much more diverse pool of candidates than we've had. And everybody's going to flock to want to work here at the University of Wisconsin. Like, why wouldn't you? And unfortunately, that's not what we experienced. We still post them in all these places. I'd say actually Twitter is the most effective, to be honest. And these societies will tag them when we post on Twitter. But what we found, and I think is no surprise, is that we still did not see as many women and very few underrepresented minorities just spontaneously applying because we posted the positions broadly. This is another, I think, key move that we've made that's made things better. We worked in partnership with our School of Medicine Public Health HR team and said, hey, if we consolidate all of our recruitment centrally, will you give us an FTE to help us with faculty recruitment? And they said yes. And that has been a total game changer. So Lee Fredericks, who has an experienced faculty recruiter, partners with our division chairs, develops the competencies, and she is busy because we're recruiting across 11 divisions all the time. But she also, this is what she does. She's an expert. We also are then able to leverage the job board scraping, it's called, that happens through, if you work with professionals, in terms of all these other places that scrape our job board and post the job in other places. And we have seen some candidates applying through those broader postings. And then Delight is also a tremendous help who facilitates the on-site visits. But as I mentioned, we did not see a flocking of more diverse candidates. And it really emphasizes, I think, what Val was saying is that there has to be tremendous intentionality. And this, cartoon on the right is supposed to represent imposter syndrome. And what I have found is that's often the case when you pick up the phone and call someone or send them a note and say, hey, here's the position, we'd love for you to apply. They're like, well, wow, I'm not ready. I don't have the right experience. And when you hop on a Zoom call with them and talk to them and learn more about them, it's never true. But it really requires that active outreach. It takes a lot of time. It takes a willingness to reach out and talk to people and sort of slowly lure them in until they apply. And we've had some fantastic candidates come in that never, ever would have applied if we hadn't done that. In fact, I would say most of the people we've ultimately ended up hiring were frequently not the people who just applied. They were the people who we identified, called, lured in through an intentional process. Lured sounds like shady somehow, but extended at reach. And I think one of the things I'm hearing a lot from my BIPOC colleagues right now is that they're actually tired of everybody contacting them because their perception, they often say or tell me, feel is that, I'm just being called because I'm Black. I've heard that numerous times from lots of colleagues. And I would just like to say that's absolutely not the case. It's because they are talented individuals who we would love to have an opportunity to get to know better and to bring in, and they meet the competencies of the role. We always start with the competencies. But I think that increasingly that perception is out there, and it might be something good to talk about in the Q&A session so that folks are not feeling that that's the case. How do we evaluate the candidates? Then once they apply, the committee reviews all of the candidates against the competencies. They rate them against the competencies, and then they make recommendations to the division chair or to myself, if it's a division chair position, for who should be invited to interview. We then have a conversation, so questions can be asked and answered about candidates who were recommended to advance or not. It is ultimately up to me to pull people up and elevate them that weren't suggested, or to downgrade someone who was suggested, depending on what the output of that conversation is. And then we select candidates for interview. The first round is always virtual. I think this has been a huge positive from COVID. It allows for confidentiality, for one thing. It allows you to interview folks without it being broadcast to the world if you do it virtually. But it also allows for a much, much more efficient process, and you can actually interview a larger pool of candidates. Again, casting that broader net to see a more diverse pool of folks than if you're just bringing everybody on site. For the on-site visit, we're very careful to follow all the HR rules, but it's important once you get to that on-site visit that you really understand what's important to the candidate. And that could range from everything from their research program to their clinical program to their family. They have kids in high school. They have a partner who needs a specific job. And so what we do is Delight meets with them and Lee meets with them and says, is there anything that's really important to you that would make the difference between you coming or not coming to UW if it seems like a good alignment. And often they will elevate many of the things I just mentioned. That then allows us to address them in the interview process. Again, much more efficient if we know they have a partner who's a physician in XYZ to be thinking and working on that early rather than late. Make the visit thoughtful. Don't just throw the spaghetti at the wall and have them meet with everyone that is available. Now that we have access to virtual formats, pick the right people and leverage a hybrid approach. You can have people meet with them by Zoom or WebEx asynchronously or during the visit while they're meeting with people in person. Recruit. Bing Rickers taught me this. Always recruit the partner in the family. It is always about the partner in the family if that is in the mix. We have just started doing this too for our leadership positions, and it is great. And often this is done for chair positions, but I found it to be hugely valuable for our division chair positions to have them give a little vision talk. And it is short, it's 30 minutes. It's tell us who you are, tell us about your leadership philosophy, and just high level, where would you like to take the division? And that's been incredibly telling. It is fascinating what people say in those talks, both for the good and the bad. And then for our in-person interviews, they are more traditional, but we still anchor to those competencies. The evaluations are anchored to the competencies, importantly. And I think that it's really critical that we have to constantly check our bias throughout the process. We've had folks who, and often it is more often are underrepresented minorities, back to that myth of meritocracy. If you're not given an opportunity to do a lot of virtual interviews, that is a skill that requires practice. And so we have elevated some individuals throughout some of our searches who maybe didn't perform as well in that virtual format, but clearly met all the competencies. And we've said, let's bring them, let's meet them, let's give them a different platform to learn more about them. So you just have to constantly check those biases as you move through the process. And then lastly, you have to do your due diligence. And this is an example of our reference check form that we've developed. I actually, many of these questions, I will give credit to Fabrizio Macalossi, because I will tell you, when he calls me to check a reference, like, he asks you all these very focused questions that you can't squirrel around if you're trying to. But you have to ask questions that give you the information that you need. And I won't read through all of these, but you need to know how people show up when they're stressed. You need to know where they're going to have difficulty in this role. And the goal of this is not that somebody will be perfect in every domain, but that you understand and have a clear vision of where they might need support and professional development, and where they might have some difficulties. And most importantly, you want to identify anybody who has disciplinary actions or issues that are being hidden, so that they don't become your problem. So in summary, process matters. And the more we can standardize our process and our approach, the better that we are going to do in terms of having a more inclusive approach and a more diverse candidate pool. And that bias mitigation is critical at every step. And some of our subsequent speakers will touch on this to a greater extent. Be intentional and do that outreach and identifying candidates. It really totally changes your pool, and be willing to pull in people who you've never heard of before. And I think that some of the best candidates we've seen are people that I've never heard of before, but they've been great. And then you have to stick to your competencies. And I will say, this is a lesson I've learned, is that we all go back to our base behaviors. So if you have somebody you really, really like, they're just like you, and suddenly you're like you find yourself making exceptions. Well, they don't really have this, but they don't need that. It'll be fine. They don't really have this. You have to really stay true to the competencies you said you needed for the role. And again, be willing to elevate a candidate who may not fit your usual mold. So, and lastly, of course, do your due diligence and use structure for that as well. So thank you for the opportunity, and I will look forward to the subsequent talks and the Q&A session.
Thank you very much, Dr. Minter. And a reminder to the audience, please post questions in the chat. We will be actively reviewing them and then pose those questions to the faculty at the Q&A at the end of the session. Our next speaker is Dr. Amy Halverson from Northwestern University in Chicago, Illinois, and she will be speaking on common bias in recruitment processes. Dr. Halverson.
Thank you. I want to say, first of all, thank you for inviting me to be part of this distinguished webinar committee. And it's humbling to follow in the footsteps of Dr. Minter and her terrific presentation. I think it's interesting. You're going to see some common themes with different spins from each of the speakers. I have no disclosures. So I'm going to talk this afternoon about different types of biases. And some of the challenges with talking about biases is there isn't always a consistent nomenclature. And sometimes there's a lot of overlap between these different types of biases. But understanding biases, being able to name those biases and recognize the biases in ourselves is the first step in addressing these biases. So when people talk about being biased or what kind of biases we have to worry about, they usually think of perception bias. This is the stereotypes and the conscious or subconscious associations related to specific groups. Racial bias, bias against older individuals, cultural biases, and in this time in the United States, there's really a significant bias that we all have related to political affiliation. We are comfortable with people that look like us, that share our similar backgrounds, and we're less comfortable with people that maybe look different, come from different places than we do. And that brings me to my next bias, which is affinity bias. That is when we like people that share some of our same characteristics or same background. So if you're looking at two applicants, you may automatically feel an affinity to someone that went to your same medical school, your same residency, or other characteristics that are similar to you. So how do you address that? You have to think about it intentionally. You may say, what is it about this person that is just like me? And a common theme that Dr. Minter mentioned that I'm going to reiterate is you have to have these list of competencies. What are the characteristics? And make sure that you proactively address and assess the candidates in those specific areas. This is a classic study. I'm just going to show this classic study where there were over 200 academic psychologists, and they were given sample CVs of both junior and senior level faculty. And the only differences were in these identical CVs was it was either a typical male name or a typical female name. And you can see from this chart that it was identical CVs. Those with a male name were thought to be more likely someone that they would hire, or for the more advanced positions, someone that they were more likely to award tenure. And this type of study has been repeated with different characteristics based on applicants with names that are associated with a particular racial group or cultural group. This has been done in the United States, it's been done in China, they're all over the world, and we get the same results, that there are definitely biases based on these, on gender, culture, race. So it's important to understand that. The next bias I'm going to talk about is maternal bias. This is most commonly affects women, but it can also affect men. Oftentimes when a candidate has children, particularly women, people may make assumptions that they're not as competent or not as committed to the position. They may think, oh, this is somebody who has kids in school, they probably wouldn't want to relocate because they wouldn't want to move their children. These are assumptions that we're making. You might wonder, well, what's going to happen when this individual goes on maternity leave? They're coming at a critical time, and how might that affect something? So it's important to be aware of that bias. Other studies have shown that women with children often are more likely to get penalized for minor mistakes. And it's important to recognize how we perceive that, especially during the hiring process. Another study looked, I thought this was interesting. This is a study by Shelley Carell, and she's the director of women leadership at Stanford. And this is a study that she did earlier in her career, but they had CVs, and they put the position of PTA coordinator on different CVs. And again, this is another study where we do look at how people respond to CVs based on their specific characteristics. And you can see that there was the women that put PTA coordinator on the CV, 79% less likely to be hired. The way this can affect men, who take paternity leave may be less likely to be promoted. And I think that it's important that we be cognizant of how we address this in the interview process. And I know we'll talk a little bit more about that subsequently. Other types of bias. Here are two images that I pulled from our institution's training on diversity and learning about bias. So if you look at these two images, think about what's the first thought that comes to your mind when you look at these pictures? What characteristics, what attributes may you draw from these individuals? Who would you most likely want to hire? So the gentleman is Bobak Ferdowsi, and you can see that he's a MIT systems engineer and a successful researcher, and he's led the Mars mission. And Ori Okola was named one of the most influential individuals, and she now runs a nonprofit organization. And so these are two highly accomplished individuals. And I know that when I did this initial exercise, outstanding leaders was not necessarily the first idea that came to my mind. And so it's important for me to recognize that. Another type of bias is horn and halo bias. So halo bias is when we identify one positive characteristic about an individual, we suddenly have a glowing perception of that individual. So examples might be if somebody has a really long list of publications, they've just really excelled in scholarship. You may try and gloss over some of their clinical accomplishments, or are they a good educator? What about somebody that has a lot of NIH funding? You may focus on that and not look at some of the other characteristics. The horn effect is the same idea, but the opposite. So what are those characteristics that you might see in an applicant that automatically will kind of turn you off before you've given them the full evaluation? For example, if somebody was a foreign medical graduate, that automatically might trigger a bias. What about if they trained at a less prestigious residency program? So it's important to recognize that and go through the rigorous exercise of checking all the competencies. Another bias is confirmation bias. So this is where we selectively amplify and ignore certain facts. So we have our preset ideas. Maybe these ideas are based on our affinity bias. Maybe they're based on our perception bias, our stereotypes, our halo and horn biases. When we come with a certain beliefs or certain biases, as we move forward, when we see things that confirm our biases, we latch onto those, and then we tend to ignore other factors. Another spin on this attribution, I'm going to go to the next one. So the next one I want to talk about is attribution bias. And beyond having the horn and halo where we focus on certain facts, the perception bias, the confirmation bias, where we focus on highlighting certain things that confirm what we already believe. Sometimes the attribution bias is just making up stories, okay? We see something about an individual and we just sort of draw conclusions. The way this may play out is a simple example is, say somebody is a little bit late for their interview, and you may think, oh, this person is totally unorganized. We could never accept this person. And then it's trying to understand the context that might be behind this person. Another way to look at attribution bias that can tie in to gender bias is that we may make assumptions that certain individuals at a level have accomplished what they've accomplished based on their innate characteristics. This person has gotten to this position because they are so incredibly intelligent and they work very hard. Whereas another person, we may say, this person has gotten to their position because they've had really good luck. It's all about their mentors. It's all about how they've been in the right position at the right time. And we don't know, but we're just, that when I talk about attribution, we're kind of making up these stories about the other person's pathway that we really don't necessarily know. So it's important to be aware of that attribution bias. We have to recognize when we see something, what our assumptions are, because the same picture can look different depending on what position we're coming from. So talking about ways to address bias, one, it's already talked about the importance of a diverse selection committee. I'll just mention that when you're putting together these committees, recognize that sometimes it's a challenge when you only have a few individuals that represent certain minorities, and they get called to be on every committee and every diversity committee, every search committee, and recognize the stress that it can put on those individuals. The second thing is bias training for the committee members. Our organization has an entire handbook on hiring protocols. And then here's just some examples of resources that our institution gives individuals to be trained on their bias. And there's good data to show that when you train individuals, for example, doing the implicit bias training, that can have a durable effect. We talked about the importance of an intentional, diverse applicant pool. And I think our next speaker is really going to focus on the standardization of interview questions and the importance of a standard evaluation rubric. And with that, I'm going to stop and I'll turn it over to our next speaker. Thank you.
Thank you very much, Dr. Halverson. I think we're going to try and get a bit of interaction with our audience. We have a few polls for the audience to participate in. So there are 4 questions here. Are you an early bird or night owl? Why did you decide to attend this event? And you're allowed to choose multiple options for this. What is your mood barometer on a scale of 1 to 10? How are you feeling today? And lastly, what is your current role? This is a multiple choice question. So we'll just give a few seconds here for our audience to vote so we can get a better idea of who's here with us today and where they are in their careers and what they're hoping to get from this session. And as a reminder, while we're voting for our attendees, we will have a session at the end for all of our faculty to answer your questions. If you post them in the webinar chat, we will be actively polling those questions. So feel free to ask questions along the way as our speakers are presenting, and we'll make sure those questions are answered at the end. So Anthony, I think maybe we've given enough time for everyone to vote. Why don't we go ahead and close the poll and we can see what those results are if you can post them. So number one, are you an early bird or night owl? It's an even distribution there. Probably reflects our diverse surgical practices. Why did you decide to attend this event? Everyone wants to learn some new things, and also others were attracted to our stellar speaker lineup. Congratulations to our speakers. And our mood barometer shows that on a scale of 1 to 10, some of us are right in the middle, but others are feeling quite good at 7 and 9. And in terms of our current roles, we have majority of senior faculty members, as well as some junior faculty members and trainees at the fellow level. Great, so thank you for participating and give us a better idea of who's with us today. And with that, we'll transition to our next speaker, which is Dr. Karen Chojnacki. She is at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania, and her talk will be on interview guidelines and negotiation practices. Welcome, Dr. Chojnacki.
Great. So hopefully everybody can see my slides and can hear me. So thank you for including me today. I geared this more toward younger faculty and residents, so it may not apply to some of the senior people, but hopefully there's still a few things in here for everybody to learn from. So we all want to recruit residents, fellows, and young attendings who will thrive in our work environments. The interview is often the first important step in that process. So how do we recruit those people who will excel? How do we figure out who to hire without just looking to fill a position with someone who fits our culture? How do we avoid our internal, cultural, and subconscious biases that we just learned about in the last presentation? And then once we find the right person or you find the right job, how do we negotiate a work agreement that is fair and gets everyone off to the right start? So good interview tactics can reduce bias in recruitment, and we'll talk about types of interviews and types of questions. We'll also talk a little bit about the use of score sheets and then cover legal versus illegal questions and how to respond to those and some points on contract negotiation. And this is important because it's been shown that companies with more diverse management teams have 19% higher revenues as a result of more innovation. Bias and culture fit and recruitment limits diversity and in theory limits revenue. And as we learned from the earlier speakers today, this is certainly true. In medicine, we all benefit from diversity and increased innovation. So we're going to talk about unstructured versus structured interviews, one-on-one interviews versus panel interviews, and the pros and cons of each. The unstructured interview is the type of interview you're most likely familiar with. There's no strict agenda, or often there's no agenda at all. The applicant sets the pace of the interview. Often it's led by open-ended questions with no or few pre-selected questions. The pros of this is that it can be tailored to the candidate. Questions can be very specific to the candidate's application and career. Questions will likely be pulled from your CV or the application and give the applicant a chance to highlight his or her successes. On the downside, this type of interview makes it difficult to compare or rank applicants because they are not asked the same set of questions. A structured interview, on the other hand, is where a specific set of questions are asked of all applicants. They are often presented in a predetermined order. The purpose of this interview is to pinpoint the job skills that are essential to the position and provide the information necessary to make hiring decisions. A well-structured interview makes it easier to evaluate and compare applicants fairly. The structure reduces bias and increases reliability and validity. Structured interviews can also be crucial in defending against allegations of discrimination in hiring or selection because all of the applicants are asked the same questions. The biggest con of a structured interview is that there's a loss of flexibility for the applicant. Again, these are the types of interviews that we'll talk about. Most of us are most familiar with a one-on-one interview. These are typically what are used for most residency applications. As you move along your career trajectory, however, you'll be asked to participate in more panel or candidate group interviews. During a panel group interview, a candidate is interviewed individually by a panel of 2 or more people. The panel can be upwards of 9 to 10, 11 people. A panel interview can create a broader picture of the candidate. It's also a useful way to get your less experienced interviewers up to speed, as they'll watch more experienced people interview. The ABS certifying exam is often the first panel interview many of us participate in. And in this type of interview, you should notice that there is one interviewer who's leading the discussions. A candidate interview is less common than a panel interview. In this type of interview, candidates applying for the same position are interviewed together. Candidates may be asked the same questions or different questions within that session, and they may also be asked to participate in a group exercise. The amount of time spent in an interview matters. More hiring mistakes are made in the first 30 minutes of an interview than any other time. This is when first impressions, personal biases, stereotypes, and prejudices unconsciously come into play. During these first 30 minutes, competency is less important than whether an interviewer likes or dislikes an applicant. Personality and first impressions are not good predictors of subsequent performance. So no hiring decision should be made in the first 30 minutes of an interview, and first impressions should be reassessed after 30 minutes. There are several different types of interview questions. Most of us are most likely familiar with open-ended questions and behavioral questions, but as your career moves forward, you'll likely be asked more situational type questions. Open-ended questions are ones we've all seen before. Why are you interested in surgery? What's the most interesting case you've seen? What would you do if you couldn't do surgery? Why did you choose colorectal? What are your strengths? What are your weaknesses? We're all pretty familiar with those. Behavioral or competency-based questions aim to discover how the interviewee performed in specific situations. This approach is based on the principle that past performance predicts future behavior. These questions are designed to determine if the candidate possesses the attributes or skills necessary for success in the position. Situational questions reveal how an applicant thinks and how she would respond or react to a given situation. These questions are based on the premise that intentions predict future behavior. Both behavioral and situational questions have strong psychometric properties. Behavioral questions primarily measure experiences and some personality traits. Situational questions better assess an applicant's job knowledge. Both are reliable. Behavioral questions have slightly more validity, and they are more resistant to a candidate faking a response. Again, as you advance in your career, you'll likely face more situational type questions. Here are some examples of behavioral questions. Please describe a situation where you had to collaborate or partner with multiple individuals to further the goals of your area. How did you balance the needs of all, and what were the results? Given what you've been able to learn about our division's strengths and weaknesses, how would you help us improve in our areas of weaknesses? And examples of situational type questions. You are routinely called to the OR to assist a colleague who is unable to complete an operation independently. You believe that patient care is compromised. How would you handle this situation? Or you and a colleague completed an unusual, difficult case. A nurse from the OR tells your chair that the case was a success because of you and fails to mention your colleague's major role. What would you do? Most interviewers will nowadays use some type of score sheet. The score sheet will include the questions used for the interview, a rating system, a comment section, and a total score. They help to keep the interview on track. They create consistency, maintain objectivity. It also helps the interview team remember the candidates. The cons of a score sheet is that it may decrease engagement. It may limit eye contact. There'll be less spontaneity. And the limited questions may cause you to miss some relevant information about a candidate. Interviewers should let you know that they're using a score sheet. This way you'll have a better understanding of what the interviewers are looking for. Transparency is a two-way street, and this allows candidates to put their best foot forward. Some interviewers will go so far as to give you the questions ahead of time. During the course of your interviews, federal laws protect you from being asked questions that could lead to discrimination. These are the laws that govern the types of questions we can be asked. Title 7 of the Civil Rights Act from 1964 prohibits questions based on race, sex, color, national origin, or religion. The Age Discrimination in Employment Act of 1967 protects workers over the age of 40, and the Americans with Disabilities Act protects employees with disabilities. But even the most well-intentioned interviewer may slip and ask an illegal question. Illegal questions are things surrounding gender, sex, sexual orientation, marital or family status, citizenship or nationality, age, religion, credit history, criminal record, disability, and military discharge. So if during the interview for the perfect job, someone asks you a question that makes you uncomfortable or that's illegal, how do you handle that situation? Well, you can try to redirect the question. You can ask why or how the question is related to the position. But most importantly, you want to remain calm and unemotional because this could be the perfect job and somebody just slipped. So here's some examples of illegal questions and how you might want to think about framing your answer. Do you think you would be able to manage a team of all men, or do you think you'd be able to manage a team of all women? So you could answer that you have a lot of experience in team management. In fact, in residency or fellowship, I won an award for my leadership. I would love to take the opportunity to tell you about that experience. Do you plan to have children, or do you plan to have more children? I'm committed to becoming a successful surgeon. Can you tell me more about the opportunities here? So it's perfectly acceptable to deflect on that question. What's your national origin? I've lived in a few different places and I'm legally able to work in the US. What religious holidays do you celebrate or observe? My schedule is very flexible. I'm sure I'll be able to work the schedule needed for the position. Do you have any physical disabilities? I'm confident I'll be able to perform the requirements of the job. And what is your negative language, or what type of accent is that? Are there languages that would be advantageous to this position? So deflect and defer are good strategies for those types of questions, all while remaining calm, unemotional, and not hostile. So after your successful interviews, you were offered your dream job. Congratulations. Now what? So before you negotiate, it's really important to sit down and have an honest discussion with yourself. What's most important to you? Is it money? Is it call coverage? And for call coverage, how much call? Where does this call happen? How many hospitals do I cover? Is it staffing? Is it important to you that you have a research coordinator or a nurse practitioner, or that you're able to build your own staff? And the answer to what's most important to you obviously be different depending on who you are and what kind of job you're looking at. So things to consider in contract negotiation. Well, certainly you want to consider compensation. What's the base salary? Are there incentives, bonuses? What are those things based on? For call, how much call? Where? How many hospitals? Is there reimbursement for call, or is it part of your agreement? If you take extra call, will you be reimbursed for that? Non-competition agreements or restrictive covenants. These agreements set a limit on where you can practice if you decide to leave your current hospital. They're usually based on a time duration and distance or range. For instance, at my hospital, the non-compete clause is 1 year in duration and has a range of 9 miles. This is significant because it precludes me or my colleagues from working at any of the other academic centers in my city for 1 year. A more rural hospital may have a non-compete clause of 3 years and up to 50 or even more miles. Restrictive covenants are difficult clauses to negotiate, but one area you can sometimes limit is the scope of the clause if you are terminated by the employer without cause, or if you terminate the contract for cause. For instance, if you're a pediatric surgeon and your hospital decides to close down its pediatric wing, you can argue that a non-compete clause doesn't apply in that situation. You were terminated by the employer without cause. Similarly, if you quit because you have proof of discrimination or your employer didn't honor some aspect of your contract, you could argue that the restrictive covenant should be null because you terminated the contract for cause. It's important to always have an exit strategy, know how many days notice you must give to terminate your work, also know what specific conduct that would be grounds for terminating your employment. Be careful of accelerated termination dates and extended separation periods. Accelerated termination allows the employer to move up an employee's end date without pay. For instance, say you give 90 days notice to terminate your position. An accelerated termination clause allows your employer to move up the end date without cause and without pay. An extended separation clause means you may have to stay at a hospital much longer than you want to. This can allow a hospital to keep you for many months after you've announced your end date. You can imagine how uncomfortable it might be to stay in a job that you had hoped to leave months ago. There's often room to negotiate these types of clauses. Benefits includes health, dental, disability, life insurance, and retirement. There's often not a lot of room to negotiate here. Most employers have formulas based on compensation. One thing to look out for is the wording around paid time off or PTO. Some employers may require you to find another physician to cover your patients while you are on PTO. You want to strike this clause if you can. Malpractice insurance. Generally, your employer will pay for at least the minimal amount required by law. Find out if the policy is a claims made policy. These policy will cover only claims made during the term of the policy. You will need tail coverage for any claims made after that term. Consider asking your employer to cover the expense of the tail coverage. Expenses clauses can cover a lot of ground, such as licensing fees, medical staff memberships, board certification expenses, CME, journal memberships, moving expenses, and potentially loan repayment. So in conclusion, don't be afraid to ask. Recognize your worth. You're valuable. You're bringing an important skill set to your hospital, but be flexible, not obstinate. Be reasonable, not difficult. Have a reason for why you are asking for what you want. Be professional always. Most likely you won't get everything you want, but if you don't negotiate, you won't get anything you want. There are resources to tell you if the offer is competitive. The AMA publishes salaries for physicians based on the type of practice, academic rank, and geographic location. Take advantage of this information. In theory, everything is negotiable. You never know what is or isn't until you try, but in general, compensation, schedule, contract duration, and expenses have some room for change. Benefits, non-competes, and insurance, less room for change. Review your contract, preferably with an attorney. It's an expense that you won't regret. And remember, if it's not in the contract, it doesn't exist. And you are bound by the contract, whether you understand what's in it or not. So to the young surgeons in the group, best of luck to all of you on the next stage of your professional development. This is what you've worked so hard for. Don't be afraid of the process.
Thank you, Dr. Chojnacki, for a great talk there and an inspirational statue there at the end, specific to Philadelphia. All right, we have another poll here, which seems to be a bit interesting and fun, hopefully. Question number one, which superpower would you like to have? Multiple choice. What is the strangest thing that you did while attending a meeting? Multiple choice. Number three, if age is only a state of mind, which category best describes your state of mind right now? Multiple choice. Interesting choices of those for that question. What is your level of understanding of this topic, which is a broad spectrum of topics? And number five, lastly, if you could bring one thing from the office to your home, what would it be? Okay, we'll give a few moments for our attendees to answer those pressing questions and hopefully engage you for our last talk here. As a reminder, please tell us where you're from today in the chat. We'd like to know who you are and where you're from. We know a little bit about you in terms of your training level and what your interests are. We're about to learn a lot more about you, I think. After Dr. Stain speaks here, we'll also open this up for the panels, the entire panel, to answer questions from the audience. We'll give it just a few more seconds here to finish out the poll. Okay, Anthony, why don't we reveal the results and see where we are? I'm curious. Okay. Which superpower would you like to have? Teleportation is the clear winner there. Though somebody already has a superpower, maybe teleportation is unique for surgeons, so we can be in multiple spots at one time, which we often do. And maybe that's the superpower somebody has. Number two, what is the strangest thing you did while attending a meeting? Wore pajamas, cooked lunch, brushed my teeth, all equal at 1/3. Okay, I won't draw any insight into those answers. If age is only a state of mind, which category best describes your state of mind right now? Mad midlifer in 2/3 and goofy grandparent in 1/3. What is your level of understanding of the topic presented today? So basic knowledge for all who answered this question. So great opportunity to expand our knowledge and to gain more expertise in this area. And then lastly, number five, if you could bring one thing from the office to your home, what would it be? My whole desk setup wins, followed by my chair. Okay, great. So without further ado, I'd like to introduce our final speaker of the evening before we transition to our Q&A session, Dr. Stephen Stain. from Lahey Hospital and Medical Center in Burlington, Massachusetts, and he will be speaking on onboarding and retention.
Oh, oops. You probably can't see that, can you?
No, it's not in the presentation. Flip it
trying.
again.
Better?
Yeah.
Is that working?
Yes.
Good.
Okay, well, thank you very much. I was honored to have the opportunity to present this topic, onboarding and retention. Not the most exciting topic in the world, but I appreciate the option. It made me think about what I was going to talk about. And for those of you who don't know, I changed jobs in January, and I was I recollected about my onboarding. The thing I wanted to make sure I didn't do was, you know, be rude to somebody and have my boss get told that this new chair they hired wasn't very polite. So the first lesson I would say is, when you're coming into a job, recognize you're kind of under the microscope, and you want to make sure that you know, you give a good first impression to everyone you meet. Let's hope you have already picked a job that's right for you, and it's important to know and think about it. You know, even now, you've been at your job 5 years. What did they hire you for? Were you hired mostly to be a clinician? Were you going to be having a teaching portfolio? Were you going to be research? Were you going to be one of those triple threats or quadruple threats, and also be a division chief as well? As you start your job, I think you should plan for career progression, and it may not happen, but I think as you start a job, at least if you're in the academic track, it probably makes sense to think about promotion. And then as you've been a place, I've moved 3 times. At some point, I've gotten to the point I'm thinking, really, I don't want to be here. And if you're at that point, it's a hard conversation. Should I stay or should I go? Every institution has their way they onboard people. I think that in my last job, I didn't do any of it. I just show up to work, I'd figure it out on the way, and that was probably a mistake. There's lots of things, you know, that you learn by going through the onboarding process, and whether that's at a hospital, a medical school, you know, some of it is just what the institutional policies are. If you're fortunate enough, it would be very, very helpful to have either a mentor or a colleague your same age who has gone through this before and who can teach you the tips of how to get through and how to be successful. Especially if it's somebody who's gone through it in the last few years, they sort of can give you a sense of what to expect as you enter the institution, how you're going to build your clinical practice. If you want to do research, what type of resources are available there. In some departments, and in some ways in all departments, you know, having a relationship with the business manager is kind of important. And that can be to explain the finances to you, to explain what the expectations of you are. But, you know, administrator or a vice president is often one of the most important people in the department. One of my secrets of how I've been successful, I've always been friends with the administrative assistant of my bosses. So it's especially nice to be, you know, nice to the dean's assistant, or my current job, the CEO's assistant. So there are times you just want 5 minutes. You just want to be able to get to them and talk to them. You may want to walk with him or her as they're going to their next meeting. Having good relations with the administrative staff around you pays great dividends. Karen sort of talked about compensation. So I've been a chair many would say for too long. And I look at it when I have these faculty who come in and ask me for a certain number. I say, I am never, it's never a problem to ask for money, but I say there's not a vault of money in the wall behind me. The money comes from somewhere, and many times we have institutional limits on what we can pay people. It is important to really know what your length of guarantee is. And probably more important is what's going to happen when you fall off that guarantee. And maybe you're in a situation where you have a certain salary for life until promotion. But many of us have lived in a productivity-based world, and knowing what that productivity is, and also what your opportunities for incentives are. Are they predefined based on dollars per RVU? Are they based on group performance? But it's really, I think, instructive to ask those questions, mostly so you have a good sense. I think that in general, health benefits are usually standard. They're not going to change them just for you. But one of the things you might, look into, what are your expenses? You don't realize until you're a member of lots of organizations, societies, how much it costs just to be a member of the societies. Not to mention go to meetings. What's the policy if you're presenting at a meeting? Are those expenses coming out of your CME expense? And sometimes that's something that there may be some negotiation either for funds from within your division or department, especially when you're in your academic growth phase, where you're going to be writing a lot of papers and going to a lot of meetings. As Karen said, there's two types of malpractice. When I was in a practice in Nashville, it was claims-based, and we had a faculty who left, before his guarantee, and he had to buy. No, he came to us from a practice in California, and he had to pay a tail. And it was sort of amazing how much it is if you're not in an occurrence-based malpractice. It gives you indefinite coverage. In every institution, you should know what it takes to leave, both from your point of view and from the institution's point of view. In medical schools, that's often defined in the faculty handbook. If not, it may be defined in your contract, whether you are being an at-will employee, or you're being the cause if you're let go for cause or without cause. I personally never believed in restrictive covenants, still don't. But when I came to my last job, they believed in restrictive covenants. It protects the practice, not the physician, but they had won twice in Supreme Court, so they put it in everybody's contract. And I had a faculty member who left us, when he relocated 23, miles away, and the restrictive covenant said 25, they took him to court and he had to pay twice his salary in damages. It's all, whether it's as the MapQuest says, or as the Kroh flies, it all matters. More often than not, what we have done is in somebody who moves within town, we give them a non-solicitation contract. But in Boston, where I'm living now, it's a wild, wild west. There are people who move from one institution to the other institution. Every domain is different. I think it's important to understand what is the expectation of you in your job, and whether you're going to have a research interest. I mean, we all can be interested in writing papers, clinical papers, but are you really going to spend a significant amount of your time in goals of trying to get extramural funding? My own bias is because, in many ways, surgery, in all ways, certainly the clinical domain, I think you have to make a real effort in your first few years in practice to establish your clinical expertise, and whatever that niche is going to be, devote lots of time to build your practice so you have something you can fall back on if your research doesn't go as well. It's hard for many people to think they have these mentors who are able to do it all, but it's a tough question to ask yourself. Do you see yourself in 5 or 8 years being a NIH-funded investigator? And I don't think it's anything, you're not a second-class citizen if you want to be a clinician. And I think sometimes people struggle with that. If you're going to have a more of an academic focus, are you in the right environment for success? And that means, have you had the right training? Have you had the right mentors? And will you actually take the time that's necessary to be successful in research? The people who are doing research, who are PhDs that you compete with for grants, are just as smart as you. And you have to spend as much time as they do, I believe, to be successful. If you go the clinical route, I think it's equally necessary to publish. And sometimes you get noticed by being on the podium giving papers and trying to attract trainees can help facilitate you doing your research. One of the things you may aspire to is ultimately to become a section chief or division chief, but on the way, how much time do you spend on committees? You know, it's been called a diversity tax. I'm sure it's a gender tax as well, but you get asked to be on a lot of committees and you have to ask yourself, do you want to not waste, spend all this time and what could be a time sink? I know one of my mentors told me not to, but I said yes to everything. And it paid off for me. I got, you know, when I got time for promotion, you know, the head of neurosurgery who I'd met on the admissions committee wrote me a letter. The vice dean of administration I knew, but it's a balanced thing that you have to decide. I'm going to talk about what things that are best practices. I'll admit I've never experienced these or been able to do these for any of my faculty. I pulled a couple of options out of off the internet. So Michigan talks about the Michigan Promise if you go to their website, and they believe that the best practice is an assigned group with multidisciplinary. It can be in the clinical areas, education, academic, and leadership. And they believe their approach is that it's a longitudinal program that's going to make everybody successful. And that takes a team of people around you. I think it is ideal. I have friends who are chairs who have recruited people, and they have had the ability to develop a research team around the junior faculty that has multidisciplinary, some people from biochemistry or the Cancer Center or other people to help make them successful. Medical College of Wisconsin has a different approach. They talk about provide a structure for formal mentoring of junior faculty, and their mnemonic is WIN. What are my 3 and 5 year goals? Importance of your CV. You know, it's interesting when we do recruiting here. Lots of people are most interested in their vision statement or how well they interview. I think the CV is really important. It's a written record of what they've actually done. I think if you're successful, you may want to try and attain leadership positions in society. That was an important part of my development. Whether or not a clinical or a modified track matters, but I think as you start on the faculty role, you know, you should have being promoted as part of your goal. It's important to know what are the requirements in your institution typically for promotion. You may be the exception. I'll tell you, when I was at USC as a junior faculty, the word was if you got 30 papers, you probably would get promoted. I only got 29, but you know, my goal was to get 30. And when I was told by my mentor, Tom Byrne, you can't write 30 papers by yourself. You have to have a group of people who work with you, who you collaborate with, and you can share on each other's research and eventually be on each other's papers. More important, or most important, I would say, you know, we talk about work-life integration, and that's an individual decision you work out with your family about how much time. I remember another good friend of mine, Nfonsam, who's now at City of Hope. He doesn't sleep, and he used to tell me that he would always have dinner with his family. Then he'd go back to work and work till midnight. And in about mid part of my career, I found myself doing that for a few years, and finally I just stopped it. And to this day, I don't work much at home. I only work at the office. And when you get to the point in your career, you're thinking about relocating, there are very, you know, tangible family costs if you decide to relocate, and the grass is not always greener. if you get to the point in your career where you are considering relocation, sometimes people offer research packages where that may be giving you an administrative position, adding to your research funds. But ultimately, are you ready for a new challenge? And I would say that my experience is that the grass is not always greener. It may be a different shade of green, but it's new challenges, and make sure that you're not leaving one opportunity for an opportunity that's just as challenging. So I participated in this task force for American Surgical. If you look it up, it's available on the website. Chapter 5 talks about a roadmap for academic success, and the chapter focuses mostly on strategy for the more junior faculty and the optimal mentoring and development of the two-way process, which involves mentoring development by your chief chair and actually also the institution. Lastly, from that same article, here's some resources that are available that give some of the development courses that are available for you to participate in that I think are great experiences that can show you more how to get your academic career going. And I really look forward to the question and answer to see if I can add any to my talk. Thank you very much. Yes, that's it.
So we're gonna go to the question and answer. I have question for everyone, and you see I have so many minorities in myself. So I'm gonna do the tough questions. So please don't ask me where my accent is coming from. I learned that today, nobody can ask me where my accent is coming from. But I'm gonna do some tough question because when you talk to people about this interesting topic today, the day by day is much more difficult than the guidelines. So I'm gonna do some questions to each of you. And I'm gonna leave Dr. Stein the last because that will be the most difficult question. So I'm gonna start. The first one, I'd like to ask this question to you, Dr. Knopf. You mentioned the mentors. So I raised with very good mentors. In my mind, the mentors have been disappearing. So how do you suggest we push for that? Should the mentorees look for a mentor? Should the mentor look for the mentorees? What do we do? Should we pick a mentor that doesn't fulfill our own characteristics so we don't look biased? Please enlighten me because it's not that easy.
So that's a very good question. I think that mentorship is critical in, advancing in whatever career path you choose. That includes surgery, and we all have mentors, no matter what station you are in life, no matter where you are in your academic career. We all have mentors, and you don't necessarily have to have a single mentor. All right, so and it's a mutually beneficial thing, and it also depends on what you want to get from that mentor or the mentor-mentee relationship. Now, you can have a mentor that helps you in your academic pursuits. You can have a mentor that helps you in your research. You can have mentors that somebody you just call for leadership. And, so again, it really depends. And if you lose your mentor along the way, that's okay. You can also, at times you outgrow your mentor or that relationship, changes over time. So there's really nothing wrong in if your mentor drops you or you drop them or something like that, or your vision or your mission in life changes. I don't think there's anything wrong. Now, I always say that your mentors can come from different places, okay? So a lot of people feel comfortable with having mentors that have the same background and same life experiences. That's amazing. That's actually really good. But you should never feel that your mentors should come from the same background like you. I can talk from my personal experience. Nearly every champion, a mentor of mine, doesn't look like me. And that was not intentional. That just seemed to happen. And so I, like a lot of mentees that I have, I always tell them, and most of them gravitate towards me because, you know, we might share the same background. I always tell them, it doesn't have to be that way. You broaden your mind. You can look at other people. You'll be surprised how much support and mentorship you can actually get from people that don't look like you.
Thank you very much. I'm going to move to Dr. Minter. And this is relatively easy, but very difficult question, Dr. Minter. My question is this one. You explained to us how bias has been sometimes the pool selection. How we prevent, and this is happening very often now in our societies, how we prevent that the new pool selection won't be now biased like it was before. So we move in opposite directions and we don't look for the real non-biased pool selection. How we do that? Because we don't want to move from A to C. We want to look for a non-biased pool selection for recruitment.
I want to make sure I understand the question. Is the question using this new approach, are we going to have just a different kind of bias? Is that the question?
Yes.
How do we avoid that?
Yes,
okay, got it. So I think that really we're humans, we're all biased. I think really the best solution to mitigating bias is to follow your competencies and follow a standard approach. You still will have bias that comes in, and that's where you have to have, you know, bias training and check ourselves against our bias. But you can have bias in both directions, right? Like you could hire somebody just because they're a specific race. That's a terrible plan because you're setting them up for failure. They don't have the competencies to do the role. And nobody wants that. And so I think that by defining and staying true to what do we need for this role, what are the competencies, it doesn't mean often that everybody meets all of them, but you know, they have to meet the majority of them if they're going to be successful, or you have to change the role and change the competencies if you're going to hire somebody who has a different set of competencies into that role, because that's the pool of people that you have. Maybe you created a position that is impossible. You know, all of these things you want don't exist in one person and nobody applies, or the people that apply don't meet the criteria. But you have to just be really intentional about that process. And then you have to hold yourself accountable. The nice thing about having a committee that has had deep bias training is that they can help hold each other accountable as well, right? It's creating a culture of identifying the bias when you see it, calling it out. I called my CEO out the other day in the gentlest of terms when he used the term foreign workforce instead of international workforce. And he actually is great. He appreciated that very much. He said, I'm very difficult to train, keep trying. So, but I think that, you know, we have to create that culture because bias will always be there. And I think the more that we create process and a standard approach and hold each other accountable, then we will make progress over time.
I'm very quick to continue this one. You think there should be like an audit group to the recruitment selection group? Somebody should be auditing that we are non-biased.
Somebody should be
auditing. Somebody
auditing the process. I might look to my colleagues, Karen and Amy, or others who have more expertise in this. I don't think I know enough about what that process would look like. I do think that it's a good idea in terms of, you know, when we look back on this new approach that we've taken, you know, a year or two from now, we need to define how are we going to know if we've made progress? How will we know if we've been successful? So I think we haven't yet. We've just been trying to keep things moving and moving forward. And I think that's a great thought about how do we measure if we've been successful or not. And then you can audit against those metrics. I think we define the metrics first.
It's an idea I throwing out there, but
yeah, it's a good one.
It will follow with the next question to both Dr. Halverson and Dr. Chojnacki. I hope I pronounce all of them well. So I hear about this illegal question and answer, but you see, I've been here 22 years and I got this question every time in written for everything I do. So if they ask it, they are not illegal. Maybe it's illegal that I have to answer them. So in the day by day, what happens if you decide to answer? Is that a bad thing for your interview? Is that a bad thing against the guidelines? Should I answer or no? Dr. Chojnacki, Dr. Halverson, should I answer these illegal questions? Are they really illegal? Day by day, because I saw the answer you gave us, they were amazing, but now I need to learn by memory like I did my step 2 exam with the actors, because I need to learn some wording. So I need to learn this wording or what do I do?
I think the most important thing is to remember that even though you may be asked a question that is technically illegal or something you shouldn't be asked, it may still be your dream job. So you want to continue to have the interview go well. So you want to maintain your poise, maintain your professionalism. And I think you answer whatever's comfortable for you. I mean, if you, one of the examples that I've seen is we're up here in the Northeast, and sometimes often we'll have residents or students come up from the South and interview, and somebody will say, "Where are you from?" And it's just a question about, it's conversation starter, but that can take on a different tone if it's an international student, if it's a student from the South. So you just have to be careful. And if your accent is clear, I'm from Georgia or fine, and you're comfortable saying that, that's okay. But I think what the interview, you just have to be careful that the person asking the question is just trying to make conversation and not trying to figure out a reason to have bias against you. If you are an international person, they may be trying to track down, figure out where you're from because they have a bias against that part of the world or something like that. So you don't have to answer that if you're not comfortable. And I think it's just, does where I'm from impact my ability to get this job? Hopefully they would say no, but if they say yes, that's a pretty big red flag that may be not the right place for you to work. So I think you just have to be aware of those types of questions and sort of have a strategy. My women residents always come back to me from fellowship interviews, and inevitably they're asked, how many children do you have, or how many children do you plan on having during fellowship? That's a very difficult question to answer, because what they're basically asking these residents is, are you going to be on maternity leave during your fellowship? And how are we going to deal with that? And how can you not view that as discriminatory? If there's going to be someone who's interviewing for the position who is clearly not going to be on a leave, and you are, is that going to be held against you? So I think you just have to have a plan. And I've always just told my residents that tell them I am committed to being the best fellow you've ever seen. And here are the things about me that are going to make me that great fellow. And that question, I really encourage them not to answer, because I think that's just a very slippery slope.
Yeah, so I will say to keep the conversation and this open, when I do interviews, I love to ask where they're from, because I find it interesting to me. I learn a lot from where they're from. It should be paranoid in every question, should be just thinking, you know what I'm saying? We should stop being ourselves, because some people, I don't assume all the time that they are going to be biased when I answer. So
no, but then what I would say is I would encourage you to ask every applicant where they're from. So the more fair way to do that is to ask the same questions of every applicant. So if every applicant that you meet, ask where they're from. That's one way to keep it more fair.
Okay, perfect.
I'll address that in a different way. I think that the best defense is a good offense. So I tell my fourth year medical students, now that they're applying for residency, is that I want them to have some key talking points. And I think this is appropriate at any level when you're doing an interview. What are the key assets that you're bringing to this position that you want to make sure people know about? The politicians do it all the time. Whatever question they're asked, they've got their talking points and they turn it around. So you need to, instead of thinking what questions you're going to answer, you think, what are the key pieces of information that I want people to know that's going to make me really terrific for this position, and think about how you're going to highlight those. And if we go back to the competencies, Dr. Minter mentioned that you go into the interview with your checkbox of competencies and you're prepared for what you're going to address. If you have a really interesting life story, even if someone doesn't ask you that question, you might want to share that and say, look at this really rich experience and background that I'm going to bring to this position.
And
Thank
if
you
I
very much. Yes, please.
I'll just add to it, because I also used to ask every applicant, where are you from? And or every medical student who came on our service, where are you from? I meet with the students every week, and that's what I would ask them. So, but I've tried to actually stop asking that question. And in the interview process now, instead of asking that question, I ask them, which I think is what Amy was just touching on, tell me about, what have been the formative life events that, have brought you to be applying for this position today. And if they, start with medical school, I say, well, I'm sure there were some things that happened before medical school that were important for your life experiences that brought you here today. And you end up getting to the same story and conversation, because I do think this question, where are you from, has become so tainted that even if it's not intended to be connected with bias, I think it's off-putting for folks. It's certainly the younger generation. I just see the antennas go up when that question gets asked. So I think there are other ways to get to the conversation that you want to have, which is to learn more about the person and what's been interesting about their life that they're going to bring to the table in terms of their life perspectives, but just figuring out how to ask it a little bit differently.
Yeah, thank you very much. I'm going to move to Dr. Stein with the opening you just gave us. I mean, great talks, amazing conversation, Dr. Stein, and this, I'm just like the devil advocate here. So we just mentioned about Dr. Minter about the youngsters. So one of the things I've seen now is that you need to treat the youngster now with a soft hand. How we handle this discipline, responsibility, all these aspects that we wanted from surgeons, and not look biased, because I mean, I punish everybody. I'm not going to punish one for, you know what I'm saying? So that's the most difficult question to me. How you keep doing what we do and don't look biased. Don't be biased. We want to be very, 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 very open to everyone. You have your microphone. Let's take, yeah.
Yeah, I would first say you have to be, I will say, quote, relatively polite. You can't yell at people anymore. But I think you have to hold them to a high standard. And I think how one does that by challenging them to be the best doctor possible is really, really important. And I tell, residents, if I start ignoring you, that's the worst thing that can happen. That means you're not worth my effort and my time. And I have residents who I believe, I know he's not in the call, but he was a chief resident once. And, attending checks one lab and they asked the residents, did you know it? And the person's PTT, after he started back on heparin, after his, his operation was greater than 200 seconds, and he didn't know it. And I said, you cannot go to your fellowship there and embarrass me. I want to hear wherever you go to your fellowship that you were a great doctor. And I said it in a way I think that was not harsh, but I think, when somebody leaves as one of your trainees, you want to be very, very proud of them. And how you instill that fact you're proud of them is, I still think of people who trained me 30 some odd years ago. So I don't think it's fair to our patients for us not to have residents become good doctors. And I'll tell one last story. One of my chief residents when I was a PG3 said, Stephen, it's not fair to your patients for you not to know anything. So that was the thing. Don't come back and not know the answer to the questions tomorrow when you ask you. So he said it in a nice way, but he told me that, Willis Wagner, the vascular surgeon at Cedars-Sinai, and he said, you have to be, well prepared. You got to work hard. Your patients deserve that. And I think if we can figure out a way to tell our residents that, I'm all for work-life integration, but the people we admire really take great care of patients, and that doesn't necessarily follow the clock. And you can train somebody in 80 hours. So I'm not saying you got to overwork them, but I think you have to figure out a way to hold our trainees and our junior faculty to high standards.
Yes, I will do my last question to you before I move to Matthew Kroh. He has some other question from the chat and from himself. Is how do we do the opposite? How we try to discipline someone without jailing? Or I never do that. With that stimulus that you mentioned before. And then they still be abused that if you don't want them in your program anymore because they're not good, you try to reorient them to a different specialty if you think they're not for this one. How do you prevent that they use this bias factor when you're trying to do something good for them, for your program, and for your patients?
You asking me again? So I mean, I think that, 20 to 23% of the people who start surgery don't finish. It's a hard specialty. And I think that, we owe it to the public to make sure the people who are going to be trained surgeons are good. But to not get yourself in trouble, you need to document, you need to give people chances, try to retrain them. And if it gets to the point where they're not going to make it, involve your DIO, involve your HR department, involve your legal department. But I don't think if you think someone's not good enough to take care of your family, then I think you're not obligated to let them finish. You just have to usher them out in a way that protects the institution and yourself.
Yes, thank you. Matthew, now it's your turn. Thank you, guys.
Thanks, all. I just have one question from the chat. This was posted earlier and maybe reflects a couple slides in Val's talk about loss along that pipeline. And this comes from a medical student. And the question that was posed was, as a student, maybe earlier along in the pipeline, how would a student search out opportunities for themselves or their peers to decrease this leak? What active role can they take earlier on in their careers where maybe there aren't so many resources dedicated to them? And that's to anyone.
So I think that our medical students should be encouraged to reach out and make those connections and ask for those opportunities. That's often not comfortable, and we all need to do a better job of reaching down and lifting up. But I think that, particularly organizations like the AAS, for example, I think is a really fantastic pipeline organization. They're very group of academic surgeons of all specialties, which is, I think, one of the really nice things about the AAS in terms of welcoming students. Also, all of the societies we've been talking about earlier in terms of SBAS, Latino Surgical Society, the Out and Allies group. There are many, many groups where I would encourage the students to join. I think that increasingly there are opportunities for the students to get involved in those societies early on. And that then creates connections that create the next opportunity, the next opportunity, the next opportunity. It's that social capital that builds through those relationships that Dr. Stain talked about, and they can begin very early. That was certainly my experience. I was also a big joiner and was very bad at saying no, but each opportunity opens the door to the next opportunity as you participate. And so that's, I think, one possibility.
I'll add to that. Our institution has several activities that proactively reach out to expand diversity. One, we have a Take Your Children to Work Day. So not just the faculty, but all the employees can bring their kids to work, and then they get to go through these educational rotations. So it can be elementary school kids, but they take them down to the sim lab and they learn about, CPR, things like that. So it's that initial exposure. Then we have a program for high school students where they come and spend a week at the institution, and we have a variety of lectures and experiences targeted to them. We have a summer internship program that more or less targets underrepresented minorities, where they spend the summer, they either do something with work or a research project, and that gets them known by our institution and it gives them that exposure. When we start recruiting medical students, we start at the M1 year. So every step of the way, it's important to give those young people a vision of what they can become. And I think this applies for rural areas. I think some people out in rural areas, they just don't even think about these careers in medicine until somebody comes to them and says, you know what, this could be an option for you. You might like this, and give them that initial spark and plant that seed.
Juan?
I really have nothing to add to all those really great answers.
Well, I would just add one thing, and you know, you've all raised great points with respect to programs that are created to engage medical students. But not every medical student is going to have the opportunity to find a program or to have such great opportunities present themselves. And I would say that to those medical students who are, you know, you have to look deep inside you and find the courage and to go seek those opportunities out. And that sometimes involves stepping outside of yourself and, you know, pushing the limits a little bit. And I think, to everyone's point, that's when you gain. You know, you take a little rest, you go out and find people that maybe you connect with. And, you know, just like one of the earlier speakers had said, they don't have to look like you. They don't have to be, you know, a brown woman like me. In fact, people who are sometimes really cognitively diverse from you are the most interesting people to engage with, who can take you and will take your hand because they're looking for you too. So I would say that sometimes stepping outside of yourself, it can lead to tremendous opportunities.
Juan?
Yes. Okay, before closing this section, I would like to take the moment to, on behalf of the Diversity and Inclusion Committee and SSAT, I want to say thank you to all the speakers for these outstanding presentations, and also for the participants to take the time to join us today. Diversity and inclusion is a critical point, and it has a tremendous value to our institutions. This is one of the biggest learning points today. And also, I have a couple of highlights that I was able to take from all the presentations, and I would like to share as a take-home messages. The surgeon's pipeline is leaking, and this is a multifactorial situation, and to plug in the leak has to be intentional. I think this is a very deep message, especially for young physicians and for future academic surgeons. Recruitment processes matters, bias mitigation is critical. We need to be intentional to identify candidates and also be willing to evaluate a candidate that may not fit the unusual mold. We need to keep in mind that there are different types of bias, and this is important to identify them in order to have a very transparent selection processes in our institutions and hospitals. Regarding the contract negotiation, this is something that we need to keep in mind, that we shouldn't be afraid to ask questions. We need to have clear in our minds what is more important for us, because every single case is absolutely different. We need to determine how competitive they offer. And if we get the chance, feel free to review this contract with an attorney. And finally, as many of you mentioned several times, mentorship is critical. This is one of the predictors of success of any academic physician, any academic surgeon. Personal and career development is critical during our pathway, and having clear goals are important for career advancement. And accomplishments play a major role in the retention, because if you don't feel that you are moving forward in your career, at some point you are gonna start thinking about to move out of the current institution. Please, for the participants, do not forget to take the survey after the end of this session. And this webinar will be available online in the SSAT website. Feel free to share this information with all your friends and colleagues. And once again, thank you so much for your active participation and for your commitment with this activity.
Thank you.
Thank you so much.
Thank you very much. Be safe.
Thanks, everyone.
Thank you.